Welcome to the deep dive. Today we're tackling a really significant area in medicine, using hyperbaric oxygen therapy, or HBOT, as an additional tool in treating serious thermal burns.
Absolutely. Thermal burns, they present a huge challenge. I mean, not just for immediate survival, but also the long-term impact on a person's life. And while they place a massive burden on healthcare systems, too.
Exactly. We're talking about helping people survive, heal as fully as possible, minimize those lasting scars, prevent complications down the line,
Yeah.
and of course do all this in a way that's, responsible economically. It's a really complex picture.
It is.
So our goal today is to really get into the evidence around HBOT for burn injuries. We want to see what the scientific research actually tells us, separating sort of the well-established findings from areas where there's still more to learn.
And it's key to remember, like you said, we're not here to share our personal opinions. We're acting as guides, basically walking you through what the research itself indicates about this therapy.
Okay, let's unpack this then. To start, it's important to understand just how big a problem burn injuries are. The American Burn Association Injury Summary Report for 2022 gives us some, well, pretty stark figures.
It really does. The overall mortality rate they reported between 2016 and 2021 was 3.2%.
Which sounds low, but
But what's really striking is how that number changes depending on age and the extent of the burn. For those under 16, it's less than 1%, which is good. But when we look at individuals over 70, it jumps up to around 10%.
and the size of the burn itself is a huge factor, right?
Oh, massive. You see less than 1% mortality for burns affecting under 10% of the total body surface area, TBSA we call it.
Right.
But that shoots up dramatically to over 60% for burns covering 70% or more. Huge difference.
Wow. And then there's inhalation injury. That seems to make things much worse.
Yeah, we also see a much higher mortality rate when someone has an inhalation injury, along with the skin burn, a significant 26.29% in those cases.
26%.
Even inhalation injury on its own has a much higher mortality rate than just skin burns alone. It's a major complication.
And it's not just about survival rates, is it? The recovery process is longer, too.
Definitely. The time spent in the hospital is also greatly affected, especially with inhalation injury. We're talking an average around 21 days compared to maybe 8 days for skin burns alone,
So almost 3 times longer.
which of course translates directly to a massive economic impact.
I bet. What kind of numbers are we talking?
Well, the average charges for people who survive burns affecting less than 20% of their body are around $323,000.
$300,000. Wow.
And for those who don't survive, it's even higher, around $427,000.
Okay.
And for really extensive burns, say between 50 and 59% TBSA, the average cost just skyrockets to over $1.3 million.
1.3 million. Those numbers are just eye-watering.
They really are.
And beyond the immediate cost, there's the increased risk of serious complications, like pneumonia, infections, respiratory failure.
Exactly, all contributing to the overall severity and, well, the cost too.
So when we talk about treating burns, there are a lot of goals we're trying to achieve, aren't there?
Absolutely. Fundamentally, it's about making sure the person survives. Then, ensuring the wound heals as quickly and effectively as possible.
Minimizing the scarring is huge too, I imagine.
Huge. And preventing any long-term functional issues. And ultimately, doing all of this in a way that's cost-effective, with the aim of getting the patient back to their life as much as possible, it's a tall order.
Okay, so we have a sense of the scale of the challenge.
Yeah.
Now let's get into how burns actually damage the body at like a physiological level. What's happening in the tissues?
Well, the initial heat damage sets off this whole cascade of events. First, you often see burn shock.
Right, the drop in blood pressure.
Yeah, blood pressure drops, the heart doesn't pump as effectively. Then the body launches these really complex metabolic and immune responses. It's a whole body thing.
And locally, at the site of the burn, there's this idea of 3 zones of damage, isn't there?
Yes, that's the classic description. You've got the zone of coagulation right in the center. That tissue is essentially irreversibly destroyed.
Gone.
Then, surrounding that, the zone of stasis. This is an area with really impaired blood flow, but it might be salvageable.
Okay, so that's the key area, maybe.
It's a critical area. And then the outer zone is the zone of erythema, just redness. But what's really important to understand is that the damage isn't fixed right away, especially in that zone of stasis and sometimes even the zone of coagulation. It can actually get worse in the first, say, 48 to 72 hours after the burn. It's dynamic.
So the damage can actually deepen and spread in those initial hours and days. That's counterintuitive.
It is, but it happens. This is largely due to problems with the tiny blood vessels, the microcirculation. You get edema formation, swelling both at the burn site and sometimes elsewhere in the body.
Right, the systemic effects.
Exactly. And the release of all these inflammatory chemicals, mediators, the tissues in that zone of stasis are essentially starved of oxygen and nutrients.
Which leads to more cell death.
Precisely. Further tissue damage. And then you layer on top of that the significantly increased risk of infection.
Which we know is a major, major killer for burn patients.
Absolutely. The skin's protective barrier is gone, it's breached, and the reduced blood flow means that the body's immune defenses, the white blood cells, can't get to the wound as effectively.
So it's like an open door for bacteria.
Pretty much. It creates an environment where bacteria can easily invade and multiply. Very dangerous.
Okay. So with that understanding of how burns damage tissue and the body's response, let's bring in our potential intervention. Hyperbaric oxygen therapy. What's the basic principle behind it?
So HBOT involves having a person breathe 100% oxygen inside a pressurized chamber, typically at pressures, 2 to 3 times higher than what we experience normally at sea level.
Okay. Pure oxygen under pressure.
Yeah. The fundamental idea is to dramatically increase the amount of oxygen that dissolves directly into the blood plasma.
Not just carried by red blood cells.
Exactly. This allows much, much more oxygen to be delivered to the injured tissues, even where blood flow might be compromised.
Okay, so it's about really saturating the damaged area with oxygen, overcoming those delivery problems.
That's the core concept.
What are the potential benefits then in the context of burn injuries that researchers have looked at?
Well, the list of potential benefits based on the research is actually quite extensive. We're talking about potentially preventing that critical loss of blood flow to the skin, what we call dermal ischemia.
Right.
Reducing the edema, the swelling that further restricts circulation, and really importantly, positively impacting that vulnerable zone of stasis.
To stop it from getting worse.
Exactly, to help prevent those partial thickness burns from converting into full thickness burns, which require grafting.
That sounds incredibly important, potentially saving tissue that might otherwise be lost. That's huge.
Absolutely. HBOT is also thought to help maintain the energy balance within the cells, kind of calm down the overwhelming inflammatory response, fight off infection by boosting the body's own defenses, and ultimately promote faster and more effective healing overall.
And have these sort of theoretical benefits actually been observed in real-world clinical studies with patients?
Many reports suggest they have, yeah, with findings like lower mortality rates, shorter stays in the hospital, fewer surgical procedures needed.
Fewer surgeries, that's key.
Definitely. Yeah. And consequently, a lower overall cost of treatment, which is also important.
Okay, here's where it gets really interesting, I think. Let's dive into the early experimental work, the animal studies that first suggested this might be a promising approach. What did researchers initially see in the lab?
Yeah, the animal research provides a really important foundation for understanding this. Back in 1970, a researcher named Gruber clearly showed that there was, well, a definite lack of oxygen hypoxia in burn tissue.
Okay, confirming the problem.
Right, and crucially, that HBOT was effective in significantly increasing the oxygen levels in that area, much more so than just having the animal breathe regular oxygen at normal pressure.
So just giving oxygen normally wasn't enough for these damaged tissues.
Right. The key insight here is that HBOT seems able to overcome the oxygen delivery limitations you see with normal breathing in severely burned tissue.
That makes intuitive sense, getting more oxygen precisely where it's most needed, bypassing damaged routes.
Exactly. Then you have Ketchum, back in the late 1960s. He reported that animals treated with HBOT after a burn showed faster healing and fewer infections.
Okay, so healing and infection control.
Yeah. And later work by Ketchum also demonstrated significant improvements in the tiny blood vessels, the microvasculature, within the burn tissue of rats.
So it wasn't just about flooding it with oxygen. It seemed to be helping the body's own circulation at that micro level, too.
That's what it looked like, helping the delivery network itself.
Interesting.
Then Hartwig and Kirst, in the 70s, they confirmed these kinds of findings and also observed a less intense inflammatory response. They suggested HBOT could be a valuable tool alongside early surgical cleaning or debridement of the wound.
Okay, working together with standard care.
Exactly. And then there's the work by Wells and Hilton. Their controlled experiments on dogs showed a substantial reduction, around 35%, in the leakage of fluid from blood vessels after a burn when HBOT was used early.
35% reduction in fluid leakage.
Yeah.
Wow, that seems really significant for tackling that initial burn shock.
It is. It's directly relevant to preventing, or at least lessening, that early and dangerous burn shock phase.
That's huge, directly addressing that initial critical physiological crisis.
Indeed. Nylander's research further supported this, showing that HBOT can reduce the generalized swelling, the systemic edema associated with burn injuries.
Okay.
And Kaiser observed something interesting in rabbits with full-thickness burns. Those treated with HBOT actually saw their wounds shrink in size initially, while the untreated wounds tended to get larger in the first few days.
Shrink. How?
Likely due to the reduction in edema, the swelling both in the wound and the subcutaneous tissue underneath. Less swelling means less tension, potentially less progression.
So, potentially reversing some of the initial damage or at least limiting its progression significantly.
That seems to be the implication.
Correct.
And Stewart and colleagues' study on rats with deep partial thickness burns was particularly insightful.
What did they find?
They found that HBOT helped preserve vital structures within the skin dermis, and really importantly, it maintained ATT levels.
ATP, the cell's energy currency.
Exactly. By maintaining ATP, it seemed to prevent those partial thickness burns from progressing and becoming full thickness burns. The untreated animals showed a clear drop in ATP and that worsening of the burn depth.
And why is ATP so important there?
Well, ATP preservation links directly to cell function. Think about things like the sodium pump, which is vital for preventing cells from swelling up with water and losing fluid.
Ah, right, like bailing water out of a leaky boat.
Kind of, yeah. If the pump doesn't have enough energy, enough ATP, the cell swells up, it leaks. This connects directly back to the reduced edema, the reduced swelling, seen with HBOT.
Okay, so maintaining cell energy helps prevent swelling.
Exactly. German Prey also reported that HBOT led to a decreased spread or extension of the burn injury in animal models. Miller and Korn demonstrated that blood flow returned to the capillaries earlier.
Better circulation again.
Yeah, and that the skin surface, the epithelium, regrew faster in animals treated with HBOT, plus less drawing out of the wound bed.
Less desiccation. Okay.
Saunders and colleagues similarly observed better blood circulation in the dermis and less damage to collagen, which is a key structural protein in the skin.
So what we're seeing consistently in these early animal investigations is that HBOT isn't just delivering more oxygen. It seems to be actively helping the body's own blood vessel network recover and function better in the injured area. Multiple positive effects.
It's a consistent picture emerging, yes, benefits across multiple aspects of how burns affect the body physiologically.
Okay. Any others?
Well, Blazer and Beneshow reported a four-fold increase in survival in rats with significant burns when they received HBOT, along with less severe burn shock.
4 times higher survival. That's striking.
It is. Mader and colleagues showed that HBOT makes those crucial infection-fighting white blood cells, the PMNLs, better at killing bacteria in oxygen-rich environments, so a direct boost to the immune fight.
Enhancing the bacterial killing power.
Right. And a more recent randomized controlled study by Billick and Raps from 2005 found positive effects on swelling, the growth of new blood vessels, that's neoangiogenesis,
Well, that's blood vessels, okay.
hair follicles, and how quickly the skin's surface layer regenerated, so effects right down to the tissue repair level.
Even down to the microscopic level, influencing tissue repair and regrowth.
Precisely. And Turkisland's research indicated that HBOT can reduce how much that critical zone of stasis progresses, especially in the first 24 hours after the burn, and speed up healing by promoting that new blood vessel formation.
Okay, so a strong preclinical case. Now, we should probably touch on some of the studies that didn't show such positive results, like the Perrin study. What's the story there? People sometimes bring that one up.
Yeah, the Perrin study in pigs is often mentioned as a negative finding. However, you have to look at the details. The way HBOT was given was quite limited, only 1 hour, at twice the normal atmospheric pressure, and just for a single day.
Just one treatment.
Pretty much. Considering how extensive and ongoing the damage from a major burn is, such a short, limited intervention might not realistically be expected to have a major impact.
Fair point. Different treatment protocol.
Right. And also, pigs have some differences in how their skin responds to burns compared to humans, like less edema formation. So the model itself might be a factor.
Okay, what about others?
Similarly, the Nicole study in rats started HBOT 12 hours after the burn, which might be considered a bit late to catch the earliest damage processes, although it did still show faster skin regrowth in partial thickness burns, even with that delay.
There's still some benefit even starting later.
In that specific outcome, yes. And there were some methodological differences in the Shoshone study compared to those that showed positive effects, which might explain why they didn't see the same benefits. Things like the burn model they used.
It sounds like the nuances of the experimental design the animal model used, the timing, the dose, the duration of the HBOT treatment, are really important factors in interpreting these results. It's not just did it work or not.
Absolutely. Context is everything. But I think it's fair to say the vast majority of the animal evidence really does point towards significant advantages of HBOT in addressing the core physiological challenges of burn injuries, the hypoxia, the edema, the microvascular damage, the inflammation.
Okay, so that's what the lab research suggests.
Yeah.
What happens when we look at the clinical experience? The studies involving human burn patients, did that preclinical promise translate?
This is where we see the potential from the animal studies start to translate into, well, hopefully, real improvements for patients. And the history here goes back quite a way.
Really? How far?
WADA in Japan, starting way back in 1965, actually noticed better burn healing in coal miners.
Coal miners.
Yeah, they were being treated with HBOT for carbon monoxide poisoning, which was common in mining. But he observed their burns seemed to heal better, too. An accidental finding, almost.
Wow. Serendipity.
Kind of. Later clinical studies by WADA and others looking specifically at burns consistently reported improved healing, shorter hospital stays, lower death rates, reduced overall treatment costs.
Okay, hitting all the key markers.
Yeah, and also less need for intravenous fluids and fewer surgical procedures required, like skin grafts.
So the consistent key insight across these early clinical observations is a trend towards faster recovery and better outcomes, particularly, it seems, in severely burned patients.
That's right. That's the pattern that started emerging.
Then we move into more structured studies, I assume.
Exactly. Hart and colleagues conducted a randomized study back in 1974. Some burn patients received HBOT, and others received a sham treatment basically put in the chamber, but without the high pressure or pure oxygen.
A proper control group. That's important.
Very important. They found significant reductions in the amount of fluid needed for resuscitation, faster healing times, and lower mortality and complications in the HBOT group compared to both the sham group and also data from a national burn registry they used for comparison.
A randomized controlled trial showing those benefits, that adds a significant level of rigor to the evidence, doesn't it?
It absolutely does. Then there was NIU's large series, looking back at patient outcomes. They also showed a statistically significant decrease in mortality among severely burned patients who received HBOT.
Lower mortality again.
And also a lower rate of infection. Interestingly, they also observed that HBOT seemed to give surgeons more time to accurately assess the burn depth.
Nice. So,
By potentially stabilizing that zone of stasis, it maybe made it easier to distinguish what tissue was definitely dead versus what might survive, possibly reducing the ultimate need for surgery or allowing for more precise surgery.
yeah, I see. That extra time for planning and assessment could be really crucial in complex burn cases.
It could be very valuable, correct? Grossman and colleagues, in a series of studies starting in the late 1970s, also reported a trend towards better survival in the more severely burned patients treated with HBOT.
Okay, another confirmation of the survival trend.
Yes. And they also saw that these patients were ready for skin grafting sooner. Their donor sites where they take the skin for grafts healed more quickly.
Faster donor site healing is a big plus. Less pain, less risk there too.
Definitely. They also noted less need for intravenous fluid, faster overall burn wound healing times, earlier separation of the dead tissue, or eschar,
Okay.
shorter hospital stays, and lower mortality rates. It's quite a comprehensive list of benefits they observed over time.
So a really consistent theme seems to be emerging here, especially from Grossman's work. Faster healing and improved survival, particularly in those more severe burns.
Generally, yes, that's the picture. Now, there was Weisbrun's study, which looked back at patient records as a retrospective study.
Okay.
They did report some negative findings related to sepsis and kidney function in the HBOT group in their analysis. Ah, okay, so not all positive.
Not entirely in that study. However, it's really interesting that in the same study, they also reported a substantial 75% reduction in the need for skin grafting in the patients who received HBOT.
75% less grafting. That's a huge difference in surgical intervention, despite the other concerns they noted.
It's a very significant difference, yes. It highlights how complex interpreting these studies can be sometimes.
Definitely. What about partial thickness burns?
Marola and Piccatelli conducted a randomized controlled study specifically on partial thickness burns. They found that HBOT led to faster healing and, importantly, less scarring.
Less scarring, that's a major quality of life outcome.
Huge. And Cianci and colleagues, through their research over the years, reported significant reductions in the number of surgical cleanings or debridements and skin graftings needed.
Fewer trips to the OR.
Right. As well as shorter hospital stays and less intravenous fluid needed for patients with large burns. These are really compelling findings, suggesting HBOT can lessen the invasiveness of treatment and shorten recovery times significantly.
That's what the data suggests. Maxwell's initial study also pointed in that direction: reduced surgery, less weight gain from all the resuscitation fluid.
Right, that fluid overload can be a problem.
It can. Also, fewer days in the intensive care unit, shorter overall hospital stays, less wound infection or sepsis, and ultimately lower costs in the HBOT group.
Okay, what about smaller, more controlled wounds? Did they test it there?
Yes, interestingly, Hammerlund and later Niesgoda and colleagues did studies on small, controlled blisters created deliberately by ultraviolet light on human volunteers.
UV blisters. Okay, like a standardized small burn.
Exactly. They found that HBOT reduced the swelling, the fluid leakage, exudation, and the redness around these blisters. And Niesgoda's study noted minimal long-term scarring.
So even in less severe, very controlled wounds, HBOT seems to have a positive impact on the inflammatory response and the healing process itself.
That's what it appears, yes. It dampens that initial inflammation.
Now, you mentioned Weisbrenn had some negative points. What about the Brannan study from 1997? That one is often cited as not showing benefits, right?
It is, yes. The Brannan study is frequently brought up as a negative study, finding no significant difference in major outcomes like mortality or grafting rates overall.
Okay.
However, even the authors of that study observed that patients in the HBOT group experienced less fluid loss from their wounds, and their wounds were noticeably drier.
Drier wounds. Why is that significant?
Well, it led to fewer dressing changes being needed, which is less disruptive for the patient and potentially less costly. And they noted it seemed associated with earlier healing, even if the major endpoints weren't statistically different in their analysis.
Ah, so maybe subtle benefits weren't captured by the main metrics.
Possibly. And interestingly, Dr. Still, who was the director of the burn center where the Brannan study was done, later commented publicly acknowledging these observations, the reduced fluid loss, and the tendency towards earlier healing in the HBOT group.
So even studies that are sometimes painted as purely negative often contain hints or specific observations of potential benefit if you dig into the details.
That's often the case, yes. Nuance is key.
And before we move on, didn't you mention something about diabetic foot burns earlier?
Ah, yes, the Jones et al. Study. That's relevant because it looked at burns in patients with diabetes who often have poor circulation in their feet.
Right, making healing much harder.
Exactly. They showed successful healing with HBOT in these difficult cases, potentially reducing the need for lower limb amputations.
Wow.
It really highlights HBOT's potential ability to improve oxygenation and promote healing in tissues where blood flow is already significantly compromised, whether by diabetes or, as we're discussing, by the burn injury itself.
That really shows the broader potential of HBOT in situations where poor oxygen delivery is hindering healing, doesn't it?
Precisely. It underscores that fundamental mechanism of overcoming hypoxia.
Okay, now let's shift focus slightly. What about those really severe cases, the ones involving inhalation injury? We talked about how dangerous that combination is.
It is. Mortality rates are very high when significant inhalation injury occurs, along with skin burns. It complicates everything.
So can HBOT help there? Or is it too risky with damaged lungs?
That's a valid concern. Ray's study looked specifically at severely burned patients who also had acute respiratory distress syndrome, ARDS, which is a severe lung injury often linked to inhalation injury.
Okay, the toughest cases.
Pretty much. They found that HBOT didn't seem to have any negative effects, even in patients meeting high levels of ventilator support and oxygen. That was important reassurance.
Okay, so it appeared safe in that context.
Yes, but more importantly, the HBOT group in their study was able to come off the mechanical ventilator significantly faster.
Faster weaning from the ventilator, that's a huge win. Reduces risks like ventilator-associated pneumonia.
Absolutely. They also spent significantly less time overall in the hospital and had a substantial reduction over $100,000 per patient on average in their total cost of care.
Wow, huge cost savings again, linked to getting off the ventilator sooner and out of the hospital faster.
That's what their data showed. It's a compelling finding for these very complex patients.
Definitely. Now, let's touch on an area that's really important for burn survivors, but sometimes maybe doesn't get as much focus in these kinds of discussions: managing pain.
That's a great point. Pain, both the immediate acute pain from the burn and the dressing changes, and also the long-term chronic or neuropathic pain, is a huge challenge for burn survivors. It significantly impacts quality of life.
Absolutely. So what does the research tell us about HBOT in this context? Can it help with the pain?
There's growing evidence suggesting it might. Sutherland and colleagues did a review looking at various studies and concluded that HBOT appears to have a significant pain-reducing or antinociceptive effect.
Okay, a general pain-reducing effect.
Yes. And Rasmussen's study, using that mild first-degree UV burn model we talked about, showed that HBOT lessened the heightened pain sensitivity, the hyperalgesia, in the surrounding unburned skin.
In the unburned skin. That's interesting.
It is. It suggests that HBOT might be having a more central effect on pain processing in the nervous system, not just acting locally at the wound site itself for pain relief.
So it appears to have broader effects on how the body perceives and processes pain signals.
It seems plausible. Gibbons et al.'s research in rats with nerve-related pain, neuropathic pain, indicated that HBOT had an anti-allodynic effect.
Allodynia, that's pain from things that shouldn't normally hurt, right? Like light touch.
Exactly. A very difficult type of pain to treat. Their study suggested HBOT reduced this, possibly through mechanisms involving opioid receptors in the brain.
Okay, potentially tapping into the body's own pain relief systems.
Possibly. Ding and colleagues found that HBOT reduced burn-induced hyperalgesia in rats, and they linked this to reducing certain inflammatory factors and helping to maintain the structure of connections between nerve cells in the spinal cord.
So acting on inflammation and nerve structures involved in pain signaling.
Seems like it. And studies by Chen and Thompson et al. Also demonstrated that HBOT could reduce nerve cell death, or apoptosis, and alleviate nerve-related pain in animal models of both burn injury and surgical injury that causes nerve damage.
This is really promising, isn't it? Considering how difficult neuropathic pain in particular can be to treat effectively in burn survivors.
It really is. The potential to reduce reliance on high doses of strong pain medications like opioids would also be a significant benefit given their side effects and risks.
Absolutely. Okay, so we've seen potential benefits across survival, healing, infection, cost, and even pain management. Let's try and tie some threads together. Can we get into the nitty-gritty of how HBOT might be achieving all these positive outcomes in burn injury? What are the proposed mechanisms of action?
Right. What's actually going on at a cellular and molecular level?
Exactly.
Well, the most obvious mechanism, as we discussed, is that it directly addresses the lack of oxygen, the hypoxia in the wound. It hyperoxygenates the tissue, delivering that crucial oxygen to cells that are struggling to survive.
Okay, step one, more oxygen.
But it seems to do much more than just that. We saw evidence in the animal studies that HBOT reduces edema, that's swelling, and also the leakage from small blood vessels, the capillaries.
Right, the Wells and Hilton study, for example.
Exactly. By reducing swelling and capillary leak, it helps improve blood flow, reduces tissue pressure, and allows that delivered oxygen to actually reach the cells more effectively. It's a synergistic effect.
Okay, so less swelling equals better delivery. And we've definitely seen evidence of its impact on inflammation throughout these studies.
Yes, it seems to modulate or regulate the inflammatory and immune responses. For example, studies show it affects how white blood cells stick to the walls of blood vessels near the injury site.
Which is part of the inflammatory cascade, right?
It is. By reducing that excessive white cell adherence, it might help prevent the runaway systemic inflammation that can be so damaging in severe burns. It kind of dials it back a bit.
Okay, calming the inflammatory storm. And what about infection? How does it help there?
Its role in fighting infection seems to work in several ways, actually.
Multiple angles.
Yeah. First, as we saw from Mader's work, HBOT makes those PMNLs, the key bacteria-fighting white blood cells, more effective at killing bacteria directly. They need oxygen to work properly.
Okay, enhances the body's own soldiers.
Right. Second, it can enhance the effectiveness of certain antibiotics, making them work better.
A synergistic effect with antibiotics, too.
Potentially, yes. And third, there's evidence suggesting HBOT might help drugs penetrate those tough bacterial biofilms.
Biofilms, those slimy protective layers bacteria form.
Exactly. They are notoriously hard for antibiotics to get through. If HBOT helps disrupt them or allows better penetration, that's a big advantage.
That's a powerful combination of anti-infective actions. Boosting immune cells, boosting antibiotics, and tackling biofilms.
It seems to be, yes.
What else? Any other key mechanisms?
Well, another fascinating area is stem cells. HBOT has been shown to encourage the release or mobilization of stem and progenitor cells from the bone marrow into the bloodstream.
Stem cells from bone marrow. How does that help the burn?
These mobilized cells can then travel to the injured area, the burn wound, and help in the healing process, particularly in forming new blood vessels. That's vasculogenesis.
So recruiting the body's own repair crews.
Kind of, yeah. This works alongside the local growth of new vessels from existing ones, which is angiogenesis. So it promotes vessel growth in two ways. It also seems to have antioxidant effects.
Antioxidant. I thought oxygen could cause oxidative stress.
It's a bit paradoxical, but while high oxygen can cause stress, intermittent HBOT seems to actually bolster the body's natural antioxidant defenses in the plasma, helping it cope better with the damaging oxygen radicals produced during inflammation and reperfusion.
Okay, strengthening the defense.
And finally, there's even some early evidence suggesting it might help protect the heart, cardiac preconditioning, and reduce damage from ischemia reperfusion injury, which is when blood flow is interrupted and then restored, something that can happen in severe trauma like burns.
Wow. It really is a complex interplay of effects, isn't it?
Yeah.
Tackling the burn injury from multiple physiological angles simultaneously.
That seems to be the case. It's not just one thing. It's this combination of effects on oxygenation, edema, inflammation, infection, vascularization, and maybe even stem cells and antioxidant defenses.
Okay. So if a burn center decides, based on this evidence, to incorporate HBOT into their treatment protocols, what are the practical things they need to consider in terms of how it's actually administered?
Right, the clinical management side. Well, first, timing seems important. Starting treatment early is generally considered beneficial.
Hourly.
Often as soon as possible after the burn occurs and the patient is stabilized, potentially even during the initial stages of fluid resuscitation. Don't wait days if you can help it.
Okay, get in there quickly. What does a typical treatment look like?
A typical course often involves sessions lasting around 90 minutes at a pressure of 2.0 to 2.4 times normal atmospheric pressure. That's 2.0, 2.4 ATA.
90 minutes. And how often?
Especially at the beginning, for severe burns, it might be multiple times a day, maybe 2 or even 3 times in the first 24, 48 hours, then tapering down to once or twice daily as things improve.
It sounds quite intensive, especially in those critical early stages.
It can be, yes, which is why it's absolutely essential to have a specialized team.
Trained staff?
Exactly. People trained and experienced in managing critically ill patients who might be on ventilators or have complex monitoring inside a hyperbaric chamber, and they need to understand the specific needs and vulnerabilities of burn patients.
Requires close collaboration, I imagine.
Definitely. Ideally, the hyperbaric unit should work very, very closely with the burn unit team. Good communication, shared protocols, collaboration among doctors, nurses, technicians, it's crucial.
And monitoring during the treatment itself.
Yes. Patients need to be carefully monitored throughout the HBOT sessions for any potential side effects or changes in their condition. Fluid management also requires close attention.
Why fluid management specifically?
Well, burn patients need massive amounts of fluid initially, but HBOT might help reduce capillary leak and edema, so fluid needs might change, and adjustments might be necessary during and after HBOT to avoid fluid overload or dehydration. It needs careful titration.
Okay. Any drug interactions to worry about?
There's one potential interaction that's often mentioned, the topical antibiotic mafenide acetate, brand name sulfamylon.
What's the issue there?
Mafenide acetate is metabolized in a way that can inhibit an enzyme called carbonic anhydrase. There were concerns that this could lead to a buildup of carbon dioxide in the tissues during HBOT, so some older guidelines suggested stopping it before treatment.
Is it still a major concern?
Its use has become less common in many burn centers now anyway, as other topical agents are available, but it's something clinicians using HBOT need to be aware of if that specific drug is being used.
Got it. And patient selection is obviously a key decision. Who are the burn patients most likely to be considered for HBOT? Is it for everyone?
No, definitely not for minor burns. HBOT is generally considered for more severe injuries. Typically, criteria might include burns affecting more than, say, 20% of the total body surface area.
Okay, large burns.
Or deep partial thickness or full thickness burns, even if smaller, that involve critical areas, think hands, face, feet, major joints, or the perineum. Areas where functional outcome and minimizing scarring are paramount.
Makes sense. Who makes the final call?
Ultimately, the burn surgeon plays a crucial role. They need to weigh the potential benefits against any risks for that individual patient, considering the severity and location of the burn, the patient's overall medical condition, stability, and the logistical aspects of treatment. It's a clinical judgment call.
Okay. Now, Circling back to something we touched on earlier, cost. Given the significant costs associated with burn care that you outlined, what's the economic thinking when HBOT is potentially added to the mix? Does it add cost or save money?
That's the million-dollar question, sometimes literally. While there are definitely costs involved in providing HBOT, the equipment, the specialized staff, the
No,
time,
that's more free.
no. But several studies, including some we mentioned like Maxwell's and Ray's, suggest that it can actually lead to overall cost savings,
How?
primarily due to those reductions we saw in the length of time patients need to stay in the hospital, particularly in the ICU, the fewer surgical procedures required, like grafting, and potentially faster rates of healing, reducing ongoing wound care costs.
So the upfront investment potentially pays off later.
That's the argument supported by a number of studies. While calculating the exact cost effectiveness across the board can be complex because every patient is different, the potential for significant savings alongside the potential for better outcomes is certainly indicated in much of the clinical research.
So investing in HBOT capability could potentially lead to better patient outcomes
Yeah.
and reduced overall healthcare expenditure in the long run, at least for appropriately selected severe burn patients.
That's the idea, yes. The economic case often aligns with the clinical case based on the available data.
Okay, let's try to synthesize all this now by looking at the bigger picture. What about meta-analyses or systematic reviews that have tried to pool the data from multiple studies? What do these larger analyses tell us?
Good question. They try to provide a higher level view. Small and colleagues did a meta-analysis, and they concluded that HBOT clearly seems to have a positive impact on the underlying pathophysiology in burns, leading to better healing and overall outcomes.
Okay, a positive conclusion there.
Yeah. They also suggested that the few studies that didn't show clear positive results likely have specific explanations, perhaps related to how the HBOT was administered, like the Perrin's study dose, or maybe confounding factors in very, very sick patient populations that are hard to control for.
Makes sense. Any others?
Whitegasser and colleagues also did a review and came out with a strong recommendation for using HBOT for thermal burns. They stated that the level of evidence supporting its use is acceptable, especially when you consider the inherent difficulties in conducting large, perfect, randomized controlled trials, RCTs, in such a diverse and critically ill group of patients.
Right, doing big RCTs in emergency burn care must be incredibly challenging.
Extremely challenging.
Yeah,
Ethically, logistically, financially.
but we also have that Cochrane review from 2009, which I know is often cited. Their conclusion was a bit more cautious, wasn't it?
It was, yes. The Cochrane Review is influential, and they took a more conservative stance. They identified only a limited number of RCTs that met their specific, quite strict inclusion criteria.
Okay.
And they felt that there were too many differences between these few trials and patient populations, HBOT protocols, outcomes measured at what we call heterogeneity, to confidently combine their results in a meta-analysis.
So they couldn't pull the data effectively.
Right. While they did acknowledge Hart's studies showing significantly faster healing times, they also pointed out limitations in the studies they did include, such as some having small numbers of patients and the methodological concerns we discussed earlier with the Brannon study, for instance.
So what was their bottom line?
Their overall conclusion back in 2009 was that while some non-randomized studies looked promising, there wasn't enough high-quality RCT evidence at that time to definitively either routinely recommend or discourage the use of HBOT for thermal burns based solely on those reviewed trials. A cautious, more research-needed stance.
It seems to create a bit of a discrepancy, doesn't it, between the more positive meta-analyses like Smol's and the caution of the Cochrane Review. How do we reconcile that?
It does highlight a tension in evaluating this kind of evidence. It's important to note that the Cochrane Review, while rigorous in its methodology focusing on RCTs, was criticized by some in the field for excluding several other types of studies.
Like what?
Studies that compared outcomes in HBOT-treated patients with carefully matched control groups, for example, which did show benefits in things like hospital stay, fluid requirements, and cost. Cochrane methodology often prioritizes RCTs above all else.
So maybe too narrow a focus.
Some argue that, yes. The authors of our main source material also emphasize that the clinical observations of experienced burn surgeons and physicians who have used HBOT extensively are a valuable part of understanding its effectiveness in the real world, even if this experience isn't perfectly captured in large randomized trials. There's a role for clinical experience alongside trial data.
The art of medicine complementing the science.
Something like that. They also mentioned the unfortunate cancellation of a large, well-designed study planned by the U.S. Army Surgical Research Center, which could have provided much more definitive evidence, but it didn't proceed for various reasons. A missed opportunity.
Ah, that's a shame. So, putting it all together now, where does all this evidence leave us? What's the main takeaway from our deep dive today on HBOT for burns?
I think the main takeaway is that the bulk of the evidence, gathered from numerous animal studies spanning decades and supported by a significant amount of clinical experience in human studies, including RCTs, cohort studies, and case series, strongly suggests that hyperbaric oxygen is a valuable adjunctive therapy, in addition to standard care for selected patients with serious thermal burns.
It's not a replacement, but an addition.
Exactly. It appears to directly address many of the critical physiological challenges we discussed: the burn shock, the inflammation, the swelling, the lack of oxygen in the tissues, the risk of infection, and the problems with healing.
And the potential benefits seem substantial, based on what we've reviewed.
They do seem substantial, yes, including the possibility, suggested by multiple studies, of improved survival rates, fewer complications, shorter hospital stays, a reduced need for surgery, especially grafting, and potentially overall cost effectiveness.
Yet, despite this body of evidence, there seems to be a gap, doesn't there, between what the research indicates and how routinely HBOT is actually used in burn treatment across different centers.
That's a fair observation. Its adoption isn't universal by any means. Some centers use it routinely for certain patients, others rarely or not at all.
Why do you think that is?
Well, factors likely include the costs and logistics of setting up and running a hyperbaric facility, the need for specialized training, maybe lingering skepticism due to the mixed messages from reviews like Cochrane, and the inherent difficulties in doing those definitive large-scale trials.
Right. But the positive experiences reported by clinicians who do use HBOT for burn patients also seem to consistently support its effectiveness, adding another layer to the evidence base.
That's true. That clinical gestalt, while harder to quantify, shouldn't be entirely dismissed. So while ideally, yes, we would always love to have more large, multi-center, randomized controlled trials for everything,
The gold standard.
the gold standard conducting such studies in acute burn care presents really significant practical and ethical hurdles, as we've said.
So, the overall picture seems to be that the current weight of evidence, while perhaps not perfect by the strictest RCT-only standards, provides a compelling argument for HBOT as a useful tool in the comprehensive care of selected thermal burn patients. It creates a unique physiological environment that seems beneficial for wound recovery.
I think that's a fair summary. It strongly suggests that HBOT deserves serious consideration and, yes, further well-designed research to refine exactly which patients benefit most and the optimal protocols, but the existing evidence is already quite persuasive for its use as an adjunct therapy.
Okay, so to quickly recap then, we've looked at a significant amount of research, animal studies, human trials, clinical reports suggesting that HBOT holds real promise in many aspects of burn care, from potentially improving survival and speeding up healing to reducing complications and maybe even costs.
And it's important for you listening to remember that the information we've discussed today reflects the medical literature available up to the time our source material was compiled, which primarily drew on data from around 2022 and 2023. Medical understanding is always evolving.
Absolutely. Which brings us nicely to our final thought for you today. Given this considerable body of evidence supporting the potential benefits of HBOT for serious burn injuries, what might be some of the barriers beyond just the need for more RCTs that are preventing its more widespread adoption? And perhaps more importantly, what could be done to help bridge that apparent gap between the research findings and everyday medical practice, ultimately to ensure that patients who suffer these devastating injuries receive the most effective care possible?
That's a really important question to ponder.
It is. We encourage you to continue exploring this important topic on your own. Perhaps look up some of the studies we mentioned and maybe even discuss it with healthcare professionals if it's relevant to you. Thanks for joining us for this deep dive.